Thank you, Dr. Basil. My friend, yes, my colleague, yes, we meet again. So thank you for Nutritia. Thank you for the invitation today to speak. It's been a wonderful day so far. We're talking about the common allergic problems, and when it comes to milk allergy, that's the commonest food allergy, so it's good to have an opportunity to talk about it. So these are my disclosures. So the agenda today, so we'll talk a little bit about prevalence, although we've already had several talks talking about how allergy is on the increase, so won't go into too much detail. We'll talk about the way that milk allergy can present through using a couple of cases. I do find that having cases that's practical to you makes you think more about how you can affect the way that you manage these patients. We'll talk a bit about what tests can we do and how then to manage milk allergy, and when do we use extensively hydrolyzed formula. So as we've already heard, allergy burden is on the increase in developing countries, and we're seeing increasing amounts of anaphylaxis, asthma, food allergy, etc. And milk allergy is the most common type of food allergy that we see, and the prevalence is up to 5%. And when we think about the Middle East, we are seeing increasing levels of asthma and eczema and hay fever across the whole of the Middle East and in the UAE, etc. So this puts it into perspective. We don't really have accurate data regarding milk allergy prevalence in the Middle East, but I'm sure as many of you are paediatricians and nurses seeing children, this is a common presentation of at least suspected milk allergy. Milk allergy is on the increase, like we said, and since 2000 it has gone up in various studies across the world. However, we need to be careful in how we diagnose milk allergy. This is a fascinating study. In fact, the dermatologist mentioned this earlier. A study published this year looking at 1,300 infants. And what the children, they were born at high risk of developing allergy, and they were randomized to having daily moisturizers or not, and seeing if that had an impact on the development of eczema and allergies. Now, when we look at milk allergy, so let me see if this works. Fine. So when we look at milk allergy, parents reported suspected milk allergy in 14% of cases. Parents reported immediate reactions in 9% of cases. However, they were all tested and challenged to confirm allergy, and only 1.4% were confirmed to have allergy. So this tells us that parents, they are trying their best, they're worried, etc. But when they think their child has milk allergy, there's a high likelihood that they don't, at least based on their perception, which is why it's important to take that accurate history and do the testing when it's available. Now, interestingly, when they look at egg and peanut, the difference wasn't so great. Peanut, the parents reported allergy 1.6%, confirmed allergy 1.5%. Of course, with peanut, if it's the IgE mediated, parents are noticing a quick reaction on eating it. But milk is more of a grey area. And this is why milk allergy is the most difficult food allergy to diagnose, because of its mixed picture, which I will talk about. And why does overdiagnosis matter? Well, it's a big problem, I think, if we do overdiagnose it. So, for example, if children are on the long-term avoidance of cow's milk, then we know that children who have milk allergy, there is impact on their growth and bone density as they get older. So it's important. So dairy is an important nutritional aspect of their diet, and we should only be avoiding it if we really need to. Cost to parents. So of course, in the UAE, Middle East, these milks that are prescribed, they are expensive. They're not often covered by insurance. They can be hard to get. It's great that we have Pepti on the market, but it's not uncommon when I'm asking a family to start an EHF, they can't find it. So, let's be making sure we are giving that right advice. There's an impact on mothers. Breastfeeding is best, and we are all encouraging that. But if a mother thinks that the child has milk allergy, she's concerned that perhaps she's passing on this allergy through her breast milk, maybe there's this formula she needs to give because she has milk allergy. This will impact on breastfeeding rates. Again, we don't want to overdiagnose. And if parents avoid a food from a young age, be it milk, egg, or peanuts, we know that avoidance for long term can lead to actual allergy if at the time that they are avoiding it, they are not allergic. So pause for thought when it comes to milk allergy. Let's get it right as we can. So this atopic march, we've discussed this already, but of course, when we look at atopic march, allergy, asthma, and eczema, they're all related. So when it comes to cow's milk allergy, really there are two types. There's the IgE mediated and there's the non-IgE mediated. And as we can see on the right-hand side, the non-IgE mediated is split into protein-induced enterocolitis, eosinophilic esophagitis, mild to moderate non-IgE mediated. Yes, sorry, the slides aren't clear. This slide set, if anybody wants a copy of this slide set, then please do email me at kidsallergy@gmail.com. I'll put my email on a slide, on a chat. So there's two types, and we're going to focus on these two types here. So let's take a first case. So I like cases, it's exciting. So Emma, she's a four-month-old girl. Now she has mild eczema and she has dry skin, which mum moisturizes, and she seems to manage her eczema fine on that. She's exclusively breastfed from birth, never had any formula, never had any dairy. Now mum has started weaning, and from 4 months, it is fine to wean. I always tell parents that between 4 and 6 months, they can wean, and I leave it to them in the main. And she started weaning and gave the child, Emma, a cereal product that contained cow's milk. Now, after 10 minutes, mum says she developed a rash on her face, she developed some swelling of her lip, and she vomited once. She came to the ER. In the ER, they gave her some Zyrtec, and the rash settled. She was discharged. By the next day, she was normal. So this is IgE mediated. How do we know this? Well, IgE mediated is based on the history. History is important. So this case, it's a rapid onset. She ate the food, and within 10 minutes, she started having symptoms. So, tick, it's quick. It's the first time she's ever had dairy, so it is happening when she has dairy, tick. The rash goes the next day, very important. These rashes don't last for days. So, okay, so if you have a child that has an urticarial rash on and off for 3, 5, 6 days, that's not food allergy. The symptoms were classical. Rash on the face, swelling, itching. So if children have a rash, it should be itching, maybe hard to know in a baby, but an older child, and vomited. So moderate symptoms. There were no severe symptoms because she didn't have signs of anaphylaxis, which are breathing difficulty, throat problems, swelling, croup, etc., loss of consciousness, pallor. Now, so the history is vital here in diagnosing IgE, and she ticks all the boxes. Any doubt? We may look at family history, etc., but really it's the quick onset and the classical symptoms of the rash and the swelling, and if severe, anaphylaxis. So she has IgE-mediated milk allergy, we suspect from the history. However, still best to do a test. And there are tests, and there's 2 tests, okay? So there's the blood test. So you could do a blood test for cow's milk IgE, okay? And if it's positive, then that does not mean she has cow's milk allergy, but it's positive in the context of a story whereby when the child had cow's milk, she had symptoms suggestive of cow's milk allergy. There's a story, there's a test, put them together, inshallah. Yeah, we have the diagnosis. Or you could do a skin prick test, okay, if you have that facility. But either one is fine, but do a test. Now, please, I'm begging, only test for cow's milk. Okay, I see children that have many spot tests. They do these food panels. Now, I know as doctors, you're trying to help the family in doing food panels, maybe trying to reassure them, trying to rule out allergy. However, food panels and positive IgE in a food the child has not eaten does not help, because then the parent is worried that the child has food allergy to that food, but they haven't eaten it. So you can't diagnose food allergy just on a test. When do you test? You test the food, the parents come with you with the story. So this child, Emma, has IgE-mediated milk allergy. What do we need to do? Well, of course, mum started weaning, so from now on, she needs to avoid all dairy products, okay? And she has a touch of eczema, keep treating the eczema, monitoring that. So consider alternative milk sources. So with weaning, mum is breastfeeding her. She can continue to breastfeed, no problem. And therefore, there's no need for formula if mum is happy to breastfeed, and she can use the breast milk if she expresses that as the milk for weaning. However, if mum is looking for a top-up formula, or she's looking for some formula, then the first line here would be an extensively hydrolyzed formula. Extensively, like Pepti, Alanova, there's several on the market, okay? Other options, if you can't find that and she needs a formula, then there's rice protein formula based on rice protein, or an amino acid formula. But amino acid formula, she doesn't need as first line, because this is a mild reaction in a child who is well. But if there's no alternative and she needs something, then that would be fine. And then we would say avoid cow's milk for 6 to 12 months. And then if we want to see whether she's outgrown it, we would see her in the clinic, repeat the test. Is the signs of still allergy? If there are, continue avoidance. If not, then we do a challenge. Now, mum wants to breastfeed, but mum asks you as the doctor, what about me eating dairy, doctor? Can I continue eating dairy? And I see a lot of children who have been told by the doctor, again, doctor is playing safe, trying to be safe, wanting to do the best, that the mum should avoid dairy, but she does not need to avoid dairy in this situation. The problem started when the child was given dairy. While mum was breastfeeding her for 4 months, if there were no problems, then there's no reason for mum to change her diet. And I just want to focus on that just a little bit regarding breastfeeding. So I'm just going to use some slides. There was a very good lecture done by Dr. Boyle at the recent allergy conference, and I'm just name checking him for his slides that they're very clear. So here we have a slide here showing on the left, we have the concentration of the milk protein, okay? And at the bottom, we have breast milk. So on the left, we have a typical level. So you see the first on the left, it's very typical, very low levels of milk protein, okay? And then the highest level on the right is a reported concentration in one mother. But formula milk concentration is 1,000 times more than the one on the right, or 1,000,000 times more concentrated than the one on the left. So instantly we can see that breast milk is very, very, very less allergenic regarding cow's milk protein than formula milk. And this is the level then for IgE mediated. Sorry, there, you see, again, way above. So the chances of a child who's breastfeeding having a reaction and it's caused by IgE milk allergy are pretty much 0%. That's IgE mediated. Now, what about non-IgE, which we will come and talk to? Well, we've done studies looking to see how much dairy, how much formula, how much milk does a child need to trigger symptoms in non-IgE mediated. And we're talking about 200, 300, 400 mils. So even for non-IgE, if we were thinking breast milk was going to trigger non-IgE symptoms, we'd need to be, that child needs to be having 1 million litres of breast milk in the average concentration, or 1,000 litres. So what I'm trying to say is let's let mums carry on dairy if it's safe and if the evidence that there's little evidence to suggest there's a problem. I'm not saying 100%, it never is. And if a child is just breastfed and there are problems, then you may consider it, but it's very unlikely. Okay, so we've talked about IgE mediated. Let's talk about non-IgE. So let's look at another case. So this is David, 3-month-old. So he's mixed fed. So lots of mums in the UAE, Middle East, across the world, mixed feed. And she's breastfeeding and formula feeding from birth. At 2 weeks of age, the child developed eczema and is scratching a lot. And here's a photo of a child like this. And we see this in the clinic. When we undress the child, ready to examine, instantly the child is starting to scratch because that eczema is irritating and is being poorly managed. There's mucus in the poo, mum says. Weight gain is good. Often these children have good weight gain. Don't rely on the weight to think whether this is allergy or not. But mum remembers from a young age, had the worst colic, but it is a bit better. And she's got reflux. All babies have reflux, okay? So what's the diagnosis? So this is non-IgE mediated, okay? Now, sorry, and she's ticking all the boxes. Now, there's a very good guideline about non-IgE mediated milk allergy called the IMAP guideline. It's open access and free. If you Google IMAP, I capital M, capital A, capital P, it's a milk allergy in infancy guideline that's been adapted for worldwide use with very eminent authors there. So do look at that. But essentially, this is non-IgE. Okay, so look at the slide on the right, because the symptoms are occurring, they're not occurring within the hour like IgE. There's no obvious pattern with suddenly having diarrhea and symptoms. It's a more chronic nature. And the problems are either gut, which are like worsening vomiting, reflux, loose stools, mucus in the stools, maybe bloody stools, food refusal, colic, and skin, okay, worsening eczema. But these symptoms are very general, aren't they? They're not like IgE mediated of rash, swelling, anaphylaxis. And this is the challenge we have in trying to diagnose this. And these symptoms that we see in non-IgE are normally found in babies. So colic, 20% of babies have colic. 25% of infants have reflux, probably more. Lots of babies have loose stools. Lots of babies have abdominal discomfort. Lots of babies have eczema, but they don't all have milk allergy triggering that. So the problem we have in diagnosing non-IgE mediated milk allergy is, how do we distinguish the ones that have milk allergy and not? So first of all, what are the clues in the history? So perhaps a baby that was breastfed and then started on some formula, and maybe the symptoms started when the child started some formula milk. So that might be a clue. If there's a strong family history of allergy, then maybe, but that's another clue. But the symptoms that we see of eczema, reflux, and loose stools, if we tried some medication, like in eczema, we've suggested using steroids and creams and got things better, but the eczema is still there, then maybe there's something driving that eczema, something in the diet. And again, multiple systems affected. So if there's eczema and gut symptoms, then that's highly likely to be milk allergy. So look for the clues in the story first, okay? And it's important to find those clues. Now, eczema is a big clue, okay? And here we have a slide looking at eczema less than 3 months or more than, and 6 to 11 months, 3 to 6 months. But what this slide tells us, Q1 is mild eczema, Q4 is severe eczema, and on the left-hand side, we've got the prevalence of food allergy. The earlier the eczema starts, as in before 3 months, and the more severe the eczema is, the more likely this child is going to have a food allergy, okay? So eczema is a big clue. So, but diagnosing non-IgE mediated is difficult because there is no single test like there is for IgE mediated. There's no skin test, there's no blood test, okay? So all we can do is try an elimination diet. And then we see how the child responds. So first of all, we've got to find the right children who need to try that. And there will be some children we try that who perhaps don't have milk allergy, but that's okay because there's still a way of finding that out. But if we suspect it, we try an elimination diet. So if the child is on cow's milk formula, we change them to ideally an EHF, extensively hydrolyzed formula. If the mother's breastfeeding only and there are symptoms, then we can suggest mum to avoid dairy for a period of time. But depending on those symptoms, and there's a lot of overlap, but that's fine. And we do it for a minimum of 2 weeks, ideally 4 weeks. Then we need to see them again, bring them back to the clinic. Now, if there's no change when they've been on this diet, then we know it's not milk allergy because we've taken out dairy from the diet, assuming that mum has followed her diet or changed the milk, there's no change. Now, but if there is an improvement, That's still not the answer, because we know, haven't we? We've said that colic and reflux are normal symptoms for many babies, and in many babies, it gets better on its own. So maybe on changing the diet and removing milk and the baby has got better, maybe it's got better because these symptoms have just resolved. So we need to challenge the baby again. We need to bring back the dairy back into the diet. So if mum was only breastfeeding, suggest mum to bring back dairy in her diet. If the child was having the specialized formula, bring back some normal formula. And then the symptoms should come back if the child has milk allergy. It's vital to do this reintroduction. This is a key take-home message, because as we've said, if we don't do that, we will be over-diagnosing some case of milk allergy, and we've discussed the issues around that. Now, the IMAP talks about how you reintroduce cow's milk into a baby. And that really is, mum may be scared to go suddenly a whole bottle of cow's milk formula. But if she's given the child some EHF or AAF, etc., you could increase the amount of normal formula and mix it in that bottle and introduce it gradually. And there's a helpful leaflet from IMAP which you can download and give to the parents. So reintroduction is vital after 4 weeks, like we said, and look for return of symptoms. And then if the symptoms return, we've diagnosed milk allergy. Then you remove the dairy again and deal with the diagnosis. So this is the guideline, okay, which the IMAP one. It's complicated, okay? And, you know, and we've talked about the key points so far, but do have a look, but it's complicated. But the key thing is, you know, if the mum can breastfeed and she's mixed feeding, can she go back on the breast milk? So this child, we've said, David, 3 months, okay, mixed feeding, okay? We've taken out dairy of the diet, the cow's milk formula. We've gone to EHF. But one option for mum, if she wants, particularly if she maybe can't find that milk, is could she consider going on to just trying to exclusively breastfeed David? Baby's 3 months, she's giving 1 or 2 bottles a day. It depends, of course. And if she does do that, then it's important to provide her some support for her in order to breastfeed more. But if that's not an option, then we support mum in her decisions about feeding and start at EHF. I would say mum can continue dairy in her diet, because the likelihood is the dairy that's triggering these symptoms is from the formula milk. If things partially improve on changing to an EHF, maybe that might be an option of mum cutting out dairy just in case, but not first line. And of course, optimize her eczema. This child is scratching. This child has eczema. Eczema is of normal skin. Dairy is maybe one trigger of many. Is mum doing the right treatment for her eczema and get that better? And eczema is really key here. And it's not uncommon. We see children like this, with bad eczema on the face, parents are worried about steroids, not doing the treatments. Yes, think about milk allergy, but get that treatment right as well. But when we would consider milk allergy and eczema is if it started early and the eczema is more severe. But get the basics right. We've been discussing this. Ointments 4 times a day. And listen, Vaseline, okay, is an excellent ointment in eczema. It's thick and it's cheap, okay? There's many products on the market and they're expensive. And my worry is that sometimes parents don't buy them because they're expensive and then they don't moisturize their child. But babies will tolerate Vaseline. Parents need to understand it's safe to use steroids. When they apply a steroid, make sure there's a 30-minute break before they apply the moisturizer. Avoid soaps, etc. And then, but if you have a child with eczema who you feel that mum is doing the right treatment, then do consider a trial of extensively hydrolyzed formula if that child is on a cow's milk formula. But listen, IgE testing in eczema. So you ask 5 doctors, you get 5 different answers. And dermatologists do like the tests. And people like testing because it feels that, you know, they're trying to help. And of course, we're all trying to help. But testing a very bad idea in eczema, because a positive test is only 50% accurate, okay? A positive food allergy in eczema means when they eat the food, that food is directly triggering the eczema. But the problem is many things trigger eczema, and we see children who have blood tests, lots of positive tests. It doesn't mean they are allergic. They go on restrictive diets, etc. If you restrict the diet and the problem does get better with eczema, bring the food back again. Don't rely on just the test to diagnose it. So we've diagnosed non-Ig mediated allergy because we reintroduced it and the problem came back. So what do we do then? So then the advice is from the guideline, look, continue cow's milk-free diet for about 9 to 12, until the child is 9 to 12 months of old, for at least 6 months. During that time, while mum is weaning, it may be worth seeing a dietitian. If mum is avoiding dairy in her diet, it's vital she has vitamin D supplements and calcium on a daily basis. Now, when the child is 9 to 12 months, then we might consider bringing cow's milk back. But this may need to be done in hospital. There may need to be a challenge if at any point you suspect that the child has IgE mediated or the eczema is getting worse. Then we might be worried about IgE mediated milk allergy that children can develop. But if the child at 1 year is good, better, start to bring it back and use the milk ladder. And this is the example from IMAP. And essentially what it's looking at is using cooked dairy like a biscuit and building it up. And we can give that to parents. So when we bring back dairy at 1 year, we're not going straight for formula. We're going for cooked dairy, muffin, cheese, yogurt, and building up. Okay. And, but it's all in that guideline there. If you want a copy of that, then contact me. So we talked about EHF, first line. When might we need amino acid formula? Well, they say 5 to 10% of children who have milk allergy perhaps still have problems with an extensively hydrolyzed formula. And what we're seeing there is because in an extensively hydrolyzed formula, the protein is chopped up, but the small bits still left behind, maybe some small proportion of people are still reacting to those small bits. In an amino acid formula, the protein is completely chopped up. So they're definitely not allergic to that. So if they don't respond to EHF, but you think they are allergic because the history was very suggestive, go to an amino acid formula. Or this paper from Roseanne Meyer, feminist dietitian, the other scenarios where you may go straight for an amino acid formula would be, look, if the child's got faltering growth, if the child has severe GI symptoms, eosinophilic esophagitis, if the child has severe eczema, then maybe what we're doing there is going straight for an amino acid because we want to get this child better because the child is more unwell. Then in the future, we may try back on the EHF. But really 90% will cope with an EHF. Other treatment options for cow's milk allergy. So we said rice-based protein formula, soya milk. That is an option if they're over 6 months. But again, probably 30–40% of children who are milk allergic may also react to soya, so we need to be careful. Amino acid, again, if there's no EHF, or in that small group who need an amino acid from the start. Oat milk, camel milk, these are fine. Most children seem to be okay with camel milk. These are fine, but not as a formula, but they can be used in their food from 6 months. But they need a formula up to the age of 1 year. What milks can't we use? So no goat's milk, okay? If you're allergic to cow's milk, you're allergic to goat's milk, same animal. And partially hydrolyzed formula. What is going on? There is little evidence to support partially hydrolyzed formula. In many countries, they don't have any partially hydrolyzed formula, okay? There's very poor evidence to suggest it's protective. And if you suspect milk allergy, then it's definitely not suitable in the treatment of milk allergy. So really the advice, if you are worried about a child who may develop milk allergy, the best thing is to breastfeed. If the mother's can't breastfeed, then give a normal formula and look for the clues suggesting of allergy. Partially hydrolyzed formula offers little protection. Last slide, lactose intolerance, lot of overlap. Listen, lactose intolerance is not an allergy. Okay, what is lactose intolerance? It's because in the gut, there's not enough lactase to digest the lactose. It's all gut related. It doesn't cause eczema, doesn't cause reflux, etc. And the symptoms of lactose intolerance are explosive watery diarrhea. I see children who have been told they've got lactose intolerance and they've got constipation. It's not lactose intolerance. and there's no real good test for it, okay? If you suspect it, again, the best thing to do is try a lactose-free diet for 2 weeks, and things should get better. And then if they do, bring it back and things get worse. Let's keep things simple. All these fancy tests that you can do, looking at the different bacteria, etc. Keep it simple, okay? And really, lactose, primary lactose deficiency, where you have it for life, is extremely rare. The most common reason is secondary to a GI infection, and then we must keep bringing lactose back into the diet to see if it's resolved. So in summary, we've talked about the difference between IgE-mediated and non-IgE-mediated, and that is crucial, okay, because it's around testing, what testing is available, and the management. The management is the same regarding EHF, but further management about when we reintroduce. So get the diagnosis right at the beginning. Breastfeeding always first line, and we should encourage continued breastfeeding even in allergy and provide the support for mums like we said. There's no test for non-IgE. The only thing we can do is do the elimination diet using an EHF and then reintroduction. Please don't forget the reintroduction. And that is the only way we do it, okay? Extensively hydrolyzed formulas are first-line treatment for the vast majority of cases CMA. There are several on the market. Do check that they are extensively hydrolyzed and try. But again, thank you for your time. I hope you found this helpful. I will put my email on there, and if anybody wants a copy, let me know. Thank you very much. Over to Basil.